Good morning, everyone. So, when you do education, you try and repeat things 3 times, but when you have a 10-minute talk, it's awfully hard to repeat things 3 times, so we repeat it in 3 different lectures. So, you guys have seen this before. Compressions matter. Our compression fractions are extremely important. We know that we try and maximize our compression fraction. We want to be above 80%. Sabine has taken what we did with pit crew and put it and re-engineered it even further, which is awesome, which means I get to go home and change stuff again. But that's what this is all about. That's what the interaction with you and the interaction between all of us is all about, because we move in leaps and bounds and we move together in lockstep, and that's a big part of it. So, we hear Corey talk the other morning and talk about all our sort of sacred cows are starting to fall by the wayside. We don't know about epinephrine, bicarb's gone, calcium's gone, all these things that we used to cling to, intubation is a tough one, is falling away. So all those things have become secondary. It's all about the compressions. We know that and we need to own that. High quality compressions, so not just rate, but depth and complete release and minimizing interruptions. Now, I put this slide in pushing the car because that was my inertia slide. So, blood has mass and so getting it moving is like inertia. It's like getting the car moving. But I probably should have put this picture in because, like you heard Sabina say with backsliding, it is a Sisyphean task to keep up with trying to get people to stay on compressions and maximizing your compression fraction. But I still believe that we are the experts in cardiac arrest resuscitation. If you don't resuscitate them in the out-of-hospital environment, they are not going to be resuscitated. So last year I did a talk on CPR under the old oak tree, and I saw a group of hands that went up yesterday. There are a bunch of people that hadn't been here before, so just because for continuity I kind of need to make this work. Basically, the idea of this story was, I'll give you the quick and down and dirty, I'm not going to repeat the whole thing, but the quick and down and dirty is, we did a cardiac arrest, we worked it on scene for about 40 minutes, we got a pulse back, we put him in an ambulance, we started moving. We're driving to the hospital, he re-arrests, the crew pulls over and stops, because that's what we do, because you can't do compressions in a moving ambulance. So we're doing compressions in the back of the truck on the side of the road. And the code commander goes, I can't do good compressions because we're all packed in here like a clown car. So he says, compressions are important, I can't do good compressions, we'll take him out of the truck. We took him out on the stretcher, we didn't take his body out, we took him out on the stretcher. Start working him on the side of the road. It's August in Austin, it's a little warm. There was a tree there, we moved him over into the shade because we were going to be there for a bit. We continued to work him, resuscitated, put him back in the truck, drove him to the hospital, the guy goes home from the hospital. So, thank you very much. We appreciate that. So the takeaway from that talk that I did was focus on the things that matter and work your cardiac arrest where they drop. So that's like the 3rd time you've heard that. Work them where they drop. Don't move them until you decide they're dead. Sorry, I just said don't move them. It's early for me too, apparently. So don't move them unless you get them back or you decide they're dead. All right, so I put this in because I thought this was great. This highly scientific Bangor Daily News looked at, this is cool. In Portland, they changed working their cardiac arrest. What they did was they stopped moving people to the hospital. They used to show up, jerk them out of the living room, throw them in a truck, drive fast to the hospital. And they couldn't save them. They changed to working them on the scene, and they tripled their results. Now, they said by avoiding time-consuming ambulance rides, so sort of a swing and a miss there, but the idea was they got in the right ballpark. So what I didn't show last year was this article which came up. So one of the other stories I told was how we had a patient that arrested as we were pulling into the ambulance bay of one of our local hospitals. And so we work people where they drop, and that means where they drop. And so it was 20 feet from the back door of the emergency department. So I didn't show this article because this generated some excitement working someone 20 feet from the back door. So this is from the Annals of Emergency Medicine. Oh, I just realized this. ROSC or death. There is no truer statement than that one, I think, right? Get it? ROSC? Okay, anyway, so this caused a big stir. So I gave this talk here, and I gave this talk at NEMSP. And so this generated a huge amount of discussion amongst our colleagues. it got one of our docs in the local area excited enough that he kind of dined me out to the ambulance folks, and they came and they talked to me about, ooh, we're working people in the ambulance bay. So, Sabine already asked the question about choreographed CPR. Someone asked a question about choreographed CPR, so I want to get a sense of how many of you folks work someone on the scene for at least 20 minutes. Okay, so that's good. How many work them until they're fixed or dead? Okay, that's less. So, how many of you stop your truck to do CPR if someone arrests in your truck? Good, okay, good. So, not necessarily condone in your system, but how many of you would do CPR in the parking lot of a hospital? Awesome. Good, good. Can you tell people that animals that? So, here's the big question. How many of you folks that are willing to do all that, how many of you get regular feedback and know the quality of your CPR? Okay, good. So this is what we use to teach our performance improvement folks. This is, on the right, that yellow stuff, is a basic PDSA cycle. It's feedback loop. On the left, you see the education and the process engineering. Our PDSA cycle drives our education and our process engineering. I think we do a really great job at education and training, and we do a great job at process engineering. This is process engineering. Pit crew, checklist, blinky lights, smart bags, that stuff. And we do a great job of educating. Educating is the piece that tells the provider what the important things are, the why we're doing things, so that when pit crew doesn't work in the back of your ambulance anymore, they know compressions are important and they can make good decisions about getting out of the truck and doing compressions on the side of the road. But what we don't do a great job all the time is getting information back to folks. And so if we're going to be the experts, we should be making sure that we're actually doing it better than other folks are. And people do what you measure, so it's extremely important to measure the things that you matter. But people do what you measure only if you tell them the results. Because if you don't tell them the result, you know what's happening, but no one else does. So measure what matters and give feedback with clear goals, so what it is you want to accomplish, how well we're doing towards it. It should be consistent in its delivery, and it needs to be as timely as possible. The more immediate, the better. So, Dr. Beck did this survey last year about how much feedback we as the Eagles have for cardiac arrest. I bet if we did this again, it would probably have gone up. But just give you a look at, do you regularly provide feedback about cardiac arrest care, and if so, is it standardized, and what mechanisms you use for feedback? So, and do you provide real-time feedback, which is the hardest thing to do, and do you have a regular award ceremony or something to that effect, because that's important as well. Tailboard, I think, is by far one of the best ways to do this because feedback is immediate. If you get people together, it promotes interaction, ideas are developed, you make changes to your process, and it also gets people working together as a team. The downside is, although it's the best way to do it, it's oftentimes very difficult because you have to have real-time data. So you have to be able to get your data out of your box and annotate it relatively quickly to be able to give that feedback. And then you have to take units out of service to be able to put this together. So I will tell you honestly, we can't do that yet. I'd love to, but we can't. So what we do is we send out an email. We look at every cardiac arrest. Jose Cabanis, our deputy medical director, looks at every single one, puts these together and sends it to every single crew member so they all see the same thing. And basically we give them the report that comes out of the back of our box, and we tell them what it is they're looking at and what they want to be, or what the things they want to look at. So what's also important is we also tell them the goal. So we tell you what you're looking at, but we remind them every time what the goal is. So they look at it and they see the goal. And we give them little reminders like high chest compression fractions are important. So they see their result and they see how they perform. Now, we've always had rate before, but now we've changed monitors. Now we're looking at depth too, so it's a whole new world of evaluation. And we ask them these questions, so they go through every time. Was it pause under 10 seconds, just like Sabina's group? Was CPR started immediately after the shock? Was the monitor charged? Was the monitor with the paddles on during CPR? Because we kept going, we'd get someone out of rhythm, we'd change the leads, and they'd re-arrest and we'd forget to put them back in. So we asked them to keep looking at that. And of course, did we do effective compressions? So I love this quote, no matter how beautiful the strategy, occasionally you have to actually look at the results. So These are ours. This is, these are median compressions month to month. The blue is manual compressions. The red is a compression device. So I think, Joe, you're going to talk about this in a little bit, but we have really no functional difference in either survival rate or our compression fractions with a compression device or manual compression. So this is medians. If you're an averages kind of person, this is our average. So we stay pretty consistently in the high 80s or low 90s for our compression fraction, which is kind of where we want to be. So working when they drop, where they drop, I think we have an engineered process, checklist, metronome, choreographed CPR. We're getting really good at this. We're refining this process. And our folks have a great understanding of what's important in cardiac arrest. So I would still say that the answer is yes, work them where they drop. We should be working folks where they drop. But we need to make sure we're measuring our performance, and we need to continuously work to refine our process like Sabine is doing. And we have to give feedback to the providers so that we promote the behaviors that we want to see and that we know are linked to good outcomes. But the next step for us is going to be to start to engage our hospital partners. Because even if we do everything right, if they don't, our outcome numbers get worse. And so we're going to go and start looking at their admission rates from the emergency department to the unit. Do they complete the resuscitation bundle? Are they not prognosticating in the first 72 hours? And what are their discharge statuses and what are their discharge rates? So with that, I will take any questions you might have. Oh, and they're popping up.